Hello friends, this is Dr. Govind Raiga. Before starting pharmacology, I will want you to write a number 891 0111 213. This is not my mobile number. Now suppose you have to remember this number. So can you remember? Obviously one number you may. But suppose you need to remember this for 6 months or 1 year. It seems difficult. Now suppose you want to remember such 1000 numbers, it seems even more difficult. So the same happens with the drugs also. We know pharmacology is a study of drugs. So it seems that there are so many drugs, they have so many side effects, so many uses, and it seems almost impossible to remember them. My job will be to make that easier. And how I will make it is, now you can remember easily. So it just becomes 8, 9, 10, 11, 12, 13. The same thing we will try to do with the drugs also. That means we will try to find out everything from the name of the drug itself. Now without wasting much time, we'll directly move to a topic. Now pharmacology, we all know it's a science dealing with drugs. Now when drugs were not there, around 10,000 years back, who was there to treat the patient? Now we know in earlier times there were no drugs, so the only thing that was treating the person was we were dependent on the God itself. Then we discovered the drugs, and what we say, when the function of God finished at D, now the function of drug has started at D. But even in today's time, we have lot of drugs. Patient is in ICU. We are giving every possible drug, but still we are not sure whether the person will survive or will not survive. So now what we say, if the drug is not working, again pray to God. So that means when the function of drug finished at G, again the function of God started. And we have no control over this gentleman. But we can very well control this thing, that means drugs. So in pharmacology, we will study about drugs which is under our control. Now when we give drug to a person, it will produce some effect on person's body, and in return person's body will produce some effect on the drug. These are the two main things that we need to study in pharmacology. One, what happened to the person, and second, what happened to the drug. So these are the two main branches of pharmacology. The first branch is called pharmacokinetics. Pharmacokinetics, it is effect of body on the drug. That means what happened to the drug when it enters the body is pharmacokinetics. Whether it is absorbed or not, it go to liver, heart, kidney, brain or any other part of the body. It is metabolized or not, how it is excreted from the body. So everything comes in pharmacokinetics. Whereas the second main branch is called pharmacodynamics. Pharmacodynamics is effect of drug on the body. So whatever happens to the body will come under pharmacodynamics. That means effect of the drug on blood pressure, heart rate, kidney, GIT, eye, everything will come under pharmacodynamics. So two main branches of pharmacology, pharmacokinetics, what happened to the drug, and pharmacodynamics, what happened to the body. Okay? Before discussing about these branches, first of all, we should know what is a drug. If we talk in simple language, drug is a substance which will treat or prevent a disease. But the definition is not so simple. Like if we talk about oral contraceptives, are they drugs? Yes, they are drugs. But for which purpose they are used? They are used to prevent pregnancy. But is pregnancy a disease? Obviously not. So that means if we are saying oral contraceptives are drugs, so that means the definition of drug should include something else also apart from disease. Pregnancy is not a disease. So drug is a substance, if we write the definition, which is intended to be used for modifying or exploring the physiological function or pathological state of the body for the benefit of the recipient. Now if we see, but all we are covering in this is, first of all, our intention is good. Remember, it is not always that we will get the desired effect, but we are intending or wanting to produce that action. Clear? So intended is important. Then it is used to modify or explore the physiological function, just like we discussed in pregnancy. We are wanting to modify the physiological function. We want to prevent pregnancy. Or the pathological state, that means a disease, for the benefit of the recipient. Remember, our intention should be to benefit the patient, benefit the person, because we can modify the physiological function by producing some harmful effect also, but we should wanting be to benefit the person. So the definition of the drug is, it is any substance which is intended to be used to modify or explore the physiological function or pathological state for the benefit of the recipient. Okay, another important thing to remember here is a word known as risk benefit ratio. Remember, no drug is absolutely safe. All the drugs can produce some harmful effect, which we commonly say are adverse effects. No drug is without any adverse effect. So basically, when we give a drug, we can provide some benefit to the person in the form of treatment of disease, or we can pose some risk to the person in the form of adverse effects. So we need to balance these two things. How much benefit we are giving, how much risk the person is having. If the benefit is more than the risk, we can use the drug. If the benefit is less than the risk, we cannot use the drug. Like same drug we can use in one condition, but we cannot use in second condition. We can take the example like thrombolytic drugs like streptokinase. Streptokinase, it break the thrombus. So we want to break the thrombus when there is obstruction of the artery. Like a person is having myocardial infarction. So coronary artery is blocked. So streptokinase can break that thrombus and it can restore the blood flow to the heart, and the heart will not die much. The tissue of heart will not die too much. But the same streptokinase also has a risk of causing breakdown of normal physiological thrombus, particularly in the brain. So if that happens, the person can develop cerebral hemorrhage. Now, if a person is having acute myocardial infarction, this person is at risk of developing severe damage to heart. So here we are ready to take the risk of cerebral hemorrhage. So we can use streptokinase in acute myocardial infarction. But same streptokinase can also treat the thrombus if it is in the veins or if it is in the small arteries, peripheral vascular disease, suppose we say. But in a treatment of peripheral vascular disease, the benefit will not be that much, so that we can take the risk of cerebral hemorrhage. So same streptokinase, although will be effective in peripheral vascular disease also, but we will not use. So streptokinase we can use in acute myocardial infarction because risk benefit ratio is better. So in all the drugs we need to discuss this thing, which ratio is better or not, only then we can use that drug. Clear? Now with all this, before starting the first parameter of pharmacokinetics, we need to discuss the routes of drug administration, by which route we can give different drugs. So route of drug administration, we can broadly divide them into local and systemic. Local route means wherever the problem is, we are directly giving the drug at that place. Like we have infection of the skin, we apply the drug on the skin. We have problem in the eyes, we give the drug as eye drops. So these are called local routes. But this thing is not practical everywhere. Like suppose we have problem in the heart.
Will you like to inject the drug directly into the heart? Obviously no. Suppose we have problem in the liver. Will we inject the drug directly into the liver? Obviously no. So how to treat the problems where we cannot directly apply the drug? So in these cases, we will make the drug reach the systemic circulation in the blood, and through the blood it will reach the target organ. So that route is called as systemic route. The name says the route by which the drug will reach the systemic circulation, and from there it will go to the target place. It is called as systemic route. Okay? Now systemic routes may be of two types. They may be through the intestine, which is called as enteral route. Enteral means intestine. Or they may be away from intestine, not through the intestine, which are called as parenteral. Par means away from intestine. Now starting with enteral routes, the drug has to reach the intestine. So we can make the drug reach the intestine by two methods, either from above, that means we can give it orally, the drug will reach the intestine, or from below, that means through rectum, we can make the drug reach the intestine. So enteral routes may be oral or they may be rectal. Okay? The main problem in enteral routes we will discuss in detail later on, that the drug when absorbed from oral or rectal route, some of the drug will reach the liver, and there some metabolism occur which is called first pass metabolism. So first pass metabolism is encountered mainly by enteral routes, that means oral or rectal route. Clear? On the other hand, parenteral, away from intestine. So that means the drug will reach the systemic circulation without going through intestine. So parenteral routes we can broadly divide into injectable routes and non-injectable routes. The drug may be given by injection or the drug may not be given by injection. So it is very common misperception that only injectable routes are parenteral. No, parenteral simply means whenever the drug is not reaching the intestine but still reaching the systemic circulation, they are called as parenteral. Now injectable routes we all know, like intravenous, subcutaneous, intramuscular, all are injectable parenteral routes, whereas non-injectable parenteral routes, in which we make the drug reach the systemic circulation without the drug going through the intestine. The examples include sublingual route. We keep the tablet below the tongue and from there it is absorbed. Or it can be transdermal route. We apply the drug as a patch on the skin, from there it is absorbed. It can be nasal route. The drug is applied on nasal mucosa, from there it is absorbed. It can be inhalational route. Through the nasal, through the airways, it will absorb, and through the lung it will go into the systemic circulation. So basically, when the drug reaches the systemic circulation without going through the intestine, it is called as parenteral route, and if it is not given by injection, it will be non-injectable. Okay, so these are the various routes of drug administration. Okay, now we can discuss the two main branches of pharmacology, that means pharmacokinetics and pharmacodynamics.
The other term for pharmacokinetics is ADME. Pharmacokinetics is also called ADME study because it deals with four main factors: A for absorption, D for distribution, M for metabolism, and E for excretion. The study of absorption, distribution, metabolism, and excretion of drugs is called pharmacokinetics. We will study these parameters one by one. We'll start from first part, that means A for absorption. Now to understand the term absorption, we'll take the example of most commonly used route of administration of drugs, that means oral route. So when we give a drug by oral route, we give the drug in the GIT. This is esophagus, stomach, intestines, and various other parts of the body. We give the drug by oral route. So drug comes through these areas into the stomach and intestines. And from these areas, we want the drug to reach the blood. So this is our blood. So drug has reached the GIT, and from here we want the drug to reach the blood. So this arrow which we have posted, this arrow is actually means absorption. So absorption means movement of drug from site of administration to blood. That is called absorption. Now it is very clear from the diagram. If we want a drug to be absorbed, it has to cross this membrane. It has to cross this membrane. So the drug which can cross the membrane will be easily absorbed, and the drug which is not able to cross the membrane will not be able to absorb. So on which factor it depends whether a drug will cross the membrane or it will not cross the membrane. The single most important factor which determines whether drug will cross or will not cross is lipid solubility. A lipid soluble drug can easily cross the membranes, whereas a water soluble drug will not be able to cross the membrane. Problem is, the same drug, it can be lipid soluble at one place in the body and it can become water soluble at some other place in the body. On which factor it depends whether a drug will be lipid soluble or it will be water soluble. Now to understand that, we will first take a very simple example of water. We know H2O is a water. Water can exist as H2O or it can exist as hydrogen and hydroxyl ions. So H2O is also water. These ionic form is also water. So water exists in two forms. This is non-ionized form and this is ionized form. The same thing can happen with the drugs also. That means they also exist in two forms, non-ionized and ionized. Suppose we take the example, the name of drug is HX. It can exist as non-ionized form HX or it can exist as ionized form H ion and X ion. Now we can very easily assume if a drug is ionized, the ions of the drug can combine with ions of water. The ions of drug can combine with ions of water. Or we can safely say the ionized fraction of a drug is water soluble. Similarly, we can also say the non-ionized fraction of a drug will be lipid soluble. So the drug exists in two forms. When it is non-ionized, it is lipid soluble. When it is ionized, it is water soluble. So which form of a drug will cross the membrane? So it will be lipid soluble form. That means it is non-ionized. So we come to conclusion that the drugs cross the membrane when they are non-ionized. But most important question is still remaining. When the drug will be ionized? When it will be non-ionized? So on which factor it depends whether the drug is ionized or it is non-ionized? So obviously it will depend upon where the drug is present. That means in which medium the drug is present. So to understand that, we'll remember very simple thing. When the medium is same, the drug will cross. You need to remember one very simple statement. When the medium is same, the drug will cross. Now what is the meaning of this term is, we are talking about two things. One is drug, second is medium. So when both are same, then the drug will cross. Suppose a drug is acidic, it will cross in acidic medium. Similarly, a basic drug will cross in basic medium. Can easily, and we know that the drug crosses when it is lipid soluble. That means acidic drug is lipid soluble in acidic medium and basic drug is lipid soluble in basic medium. And we just discussed which form of a drug is lipid soluble. Yes, it is non-ionized. So that means acidic drugs are non-ionized in acidic medium and basic drugs are non-ionized in basic medium. So that means they are lipid soluble, so they can cross the membrane. The opposite is also true. When the medium is not same, they will not cross. That means acidic drug do not cross in basic medium and basic drug do not cross in acidic medium. And we know the drug do not cross because it become water soluble. And the drug is water soluble because it has become ionized. So this is the fundamental principle in pharmacokinetics. Not only pharmacokinetics, it will come again and again in every chapter of pharmacology. So when a drug crosses the membrane, when it is lipid soluble, when it is water soluble, so we can remember everything from one simple statement. When the medium is same, the drug will cross. Okay? Now we will apply this principle to pharmacokinetics, or we can say absorption. So we were talking about oral route of drug administration. So we give a drug orally. Suppose we give a drug like aspirin. Aspirin we all know is acetyl salicylic acid. That means it is an acidic drug. So when we give any substance orally, even if we give aspirin orally, it will come in the GIT and come to stomach. And we know medium in the stomach is acidic. So we know drug is acidic, medium is acidic, so it will easily cross the membrane. So we can easily assume that acidic drugs, they are mainly absorbed from stomach based on pH relation. On the other hand, if we give a basic drug like morphine by oral, so morphine is a basic drug, but when we give any substance orally, it will come to stomach. So morphine will also come to stomach. Now the problem is drug is basic, but medium in the stomach is acidic. So medium is not same. So when the medium is not same, it will not cross. The morphine cannot be absorbed from stomach. So when it is not able to be absorbed, what it will do is it will go down. It will come in the intestine. In the intestine, medium is basic. Now the drug is basic, medium is basic, so it will be absorbed from intestine. So based on pH relationship, we can safely say acidic drugs are absorbed from stomach and basic drugs are absorbed from intestine.
So we discussed that acidic drug, it will cross the membranes in acidic medium, whereas basic drug will cross the membrane in basic medium. Any problem in understanding? Any queries? Any doubts? No? I have the doubt. We say that acidic drug cross in acidic medium. What do you mean by acidic medium? Yes, pH less than 7. So that means if the medium has pH of 6, is it acidic? Yes, it is acidic. If the pH of a medium is 5, is it acidic? Yes, it is acidic. pH 4 is acidic, 3 is acidic, 2 is acidic. Now we just discussed that acidic drug cross in acidic medium. Does it not dependent on pH? If the medium has pH of 6, 5, 4, 3, will the ability to cross the membrane remain same? So, okay. So here comes the basic fundamental rule in pharmacology. Not only pharmacology, almost in whole medicine, there is one rule that there is no rule. Meaning is, when we say the drug crosses the membrane, it does not mean 100%. So whenever in any MCQ, the option contains always or never, read it very carefully. Mostly these are wrong options because always and never, 100%, 0% rarely happens in the body. Okay? So when we say a drug crosses the membrane, we say acidic drug cross in acidic medium, we does not mean 100%. We mean most of it will cross. If the medium becomes still more acidic, still more will cross. If the medium becomes slightly less acidic, slightly less will cross. Okay? So here we will want to quantify exactly how much percentage will cross and how much percentage will not cross in different media. Okay? So to understand that concept, we'll take an example. We should know the three important things. One, we should know nature of the drug, whether the drug is acidic or it is basic. Second, we should know the pH of the medium, whether the medium is acidic or basic and what is the exact pH. But third important thing we need to aware about is pKa. pKa. What is pKa? It is acidic dissociation constant. Meaning, it is that pH of the medium at which 50% of drug is lipid soluble, 50% is water soluble. That means 50% can cross the membrane, 50% cannot cross the membrane. Okay? So that pH is known as pKa. So if we know these three things, then we can exactly tell how much of a drug will cross and how much will not cross. So we'll like to understand with an example. Suppose we are talking about some acidic drug whose pKa is suppose 6. One thing important to remember, acidic drugs need not necessarily have pKa less than 7 and basic drug more than 7. Usually it happens, but even some acidic drugs have pKa more than 7. Some basic drugs are less than 7. So this is just an example we are taking. So we have an acidic drug whose pKa is 6. And we want to know at a different pH how much of a drug crosses and how much of a drug do not cross. Okay? So we will make a table. So here we will say how much drug is lipid soluble, that means how much crosses, and how much drug is water soluble, how much do not cross. And here are the different pH values. Remember, the drug is acidic, the pKa is 6. If we place this drug in a medium whose pH is 6, so how much will cross, how much will not? 50-50. So that is the definition. So 50% of a drug is lipid soluble and 50% of a drug is water soluble at pH is equal to pKa. Now suppose we place this drug in a medium whose pH is 5. So one thing we know, the pH is not 6. That means this drug will not have 50-50. That means 50% lipid soluble, 50% water soluble will not be there. Second thing what we notice, the medium become acidic. From 6 it has become 5, which is acidic. The drug is acidic, medium is acidic. So that means more should cross. So two things we know, the lipid soluble fraction should be more. Okay? Lipid soluble fraction should be more. Okay? So with 1 unit change in pH from pKa, this ratio from 50 suddenly become 10. So total is 100. So lipid soluble will be 90% and water soluble will be 10%. Okay. Similarly, if we place the same drug in the pH of 7, pH 7 is, no, it's not basic. I had read pH 7 is neutral. Yes, it is neutral, but it is basic as compared to 6. So we have to see the baseline, which is pKa in our case. So it is basic as compared to 6. So when the pKa is 7, that means that medium has become basic. So pH is 7, the medium has become basic. The drug is acidic, medium is basic. So that means more will be water soluble. Again, 1 unit change in pH. So it will ratio will be 90-10, but it will be reverse now. So 10% can cross, 90% cannot cross. Clear? Now suppose we place this drug in a medium whose pH is 4. That means it has become even more acidic. So that means even more should cross. So instead of 90, now the lipid soluble fraction become 99%. The water soluble remain 1%. Same if we place in medium 8, it become even more basic. So that means even lesser will cross. So instead of 10%, only 1% can cross and 99% cannot cross. Clear? If we place this drug in a medium whose pH is 3, then even more will cross. So it will be 99.9%. This will be 0.1%. Similarly, if we place at a pH of 9, it will be 0.1% is lipid soluble, 99.9% is water. If we further change the pH, like if we make the pH 10, the ratio will be 0.01% and 99.99%. So you can keep on extrapolating this. So from this information, we can exactly know how much drug can cross and how much a drug cannot cross in different media. Clear? Now you have read this thing earlier also, without knowing that you have read. Where you have read? You have studied this in biochemistry, you have studied this in physiology, and you have studied this in pharmacology also. But without knowing that you have studied this, you have studied this in the form of an equation which is called as Henderson-Hasselbalch equation. Henderson-Hasselbalch equation, which says that pH is equal to pKa plus log non-ionized fraction of a drug divided by ionized fraction of a drug. This you study. If we put the values here, the answer will be same. Okay? So basically it is a simplified version of Henderson-Hasselbalch equation.
So whenever we give any substance by oral route, after absorption, it will reach first of all liver via the portal circulation. Through the portal circulation, everything reach the liver first. So when we give a drug, like we give any drug 100 molecules by oral route, so these will also come into liver. Suppose we give 100 molecules, and out of the 100 molecules, suppose 20 molecules are not absorbed and they are excreted in the feces as such. So rest of the 80 molecules will be absorbed and go to liver. We'll say absorption of this drug is 80%. So 80% drug reach the liver. But we do not want the drug in the liver. We want the drug in systemic circulation, because finally the effect will be produced by the drug which is present in the systemic circulation. So this is blood or systemic circulation. So these 80 molecules which have been absorbed, they should reach the systemic circulation. But before the drug reach the systemic circulation, some of the drug is broken in the liver. Like out of 80 molecules, suppose 30 molecules are broken in the liver. So only 50 molecules will reach the systemic circulation. Now if we see carefully, we have given 100 molecules by oral route, but out of that only 50 molecules will be able to produce the action. 100 molecules are given, but only half of them, that means 50%, will be able to produce the action. Or in other words, we can say only 50% is available to produce the action. So other way of saying this is only 50% molecules are biologically available. So this fraction is known as bioavailability. Bioavailability. So we can remember this concept, biologically available. So whatever drug we have given, how much percentage is biologically available to produce the action is called bioavailability, or in simple words, it is the fraction of given dose which reach the systemic circulation. So the obvious clinical importance of bioavailability will be, if a drug has higher bioavailability means more drug is available to produce the action. If a drug has lower bioavailability means less drug will be able to produce the action. So that means bioavailability will determine the dose of a drug. If bioavailability is high, we can give low dose. If bioavailability is low, we have to give high dose of a drug. Now from this discussion, we can also find out which factors affect bioavailability. Now you can see that in this example, bioavailability is 50%. Now why it is 50%? Because rest of the 50% is wasted. So where it is wasted will determine the bioavailability. So we discussed two main areas where the drug is wasted. One is here and second is here. That means 20% of drug is not absorbed. Or in other words, we can say 80% is absorbed. So the main factor affecting bioavailability is absorption. If a drug has more absorption, it is likely to have more bioavailability. On the other hand, if a drug has less absorption, obviously the bioavailability will be less. Now the second factor affecting is this metabolism. And this metabolism which is occurring is called as first pass metabolism. The other term for this is pre-systemic metabolism. So bioavailability will depend upon pre-systemic metabolism or first pass metabolism. If first pass metabolism of a drug is high, what will happen to bioavailability? Obviously it will be lower, because if out of 80, 30 molecules are broken, then 50% will reach. But if out of 80, 70 molecules are broken, then only 10 will be able to reach the blood. So first pass metabolism, if it is higher, bioavailability is likely to be low. One last thing, if we give a drug by IV route, intravenous route, what is likely to be bioavailability? Obviously it is 100%. So bioavailability of all the drugs by IV route is 100%. Now to understand the importance of first pass metabolism, we will take an example which is very good example. It is nitroglycerin. Nitroglycerin is a drug which has almost 100% absorption. That means when we give nitroglycerin by oral route, nothing is excreted in the feces. Almost all 100% reach the liver. So it should have good bioavailability. But no, it has very poor bioavailability. The reason is it has almost 99% first pass metabolism. That means when we give nitroglycerin orally, although almost 100 molecules reach the liver, but 99 molecules are broken in the liver and only 1 or 2 molecules are able to reach the systemic circulation. So if we give nitroglycerin by oral route, it is likely to have poor bioavailability. So we use it by alternative route, and that route is called sublingual route. Sublingual, as the name tells, lingual means tongue. Lingual means tongue, sub means below. So in sublingual route, we keep the tablet below the tongue. Now on the under surface of tongue, there is presence of a vein called lingual vein. In the undersurface of tongue, there is a vein called lingual vein. So when we keep a tablet below the tongue, means we are keeping it over the vein. So now the drug can directly go into the systemic circulation. So when we give nitroglycerin by sublingual route or any drug by sublingual route, it will directly reach the systemic circulation. So what will be the advantage? There is no first pass metabolism. The main advantage of this sublingual route is there is no first pass metabolism. Any other advantage of this route? Now you can see from the diagram very clearly, when we give a drug sublingually, it will directly reach the systemic circulation. On the other hand, if we give a drug by oral route, first of all, it will reach the esophagus, stomach, intestines. From there, it will be absorbed and it will go to liver. And from the liver, it will go to systemic circulation. Then the action will come. So that means oral route, the drug will take around 40-50 minutes to act. But by sublingual route, the action will start in few seconds only. So sublingual route, the main advantage, it is very fast acting. And what is the advantage of fast action? Advantage of fast action is we can use the drug in emergencies. Nitroglycerin is used in acute attack of angina, which is an emergency, by sublingual route. Now, any other advantage of sublingual route? Now, asking the question in other format, can we give nitroglycerin by IV route, intravenous route? Yes, we can give IV, but we commonly do not use IV. The reason is every person do not develop angina at hospital. Most of the time angina occurs at home. So when the angina occurs at home, we have to treat at home. And for giving intravenous injection, we require some expert person who is well versed with the technique of IV injection. And these doctors or nurses are not available in every home. So we have to take the patient to hospital, and that will spend around 20, 30, 40 minutes, which we do not have. Whereas in sublingual route, the main advantage is self-administration is possible. The person has to keep the tablet below the tongue, which anyone can keep. So there is no requirement of any assistant. Self-administration is possible. That is the major advantage of sublingual route. And lastly, one main advantage of sublingual route is we can take in this manner. Suppose we give 5 milligram of nitroglycerin by sublingual route. When we give sublingually, suppose out of the 5 milligram, 3 milligram reach the blood, and now the chest pain subsides. Angina is treated. Now what happened to rest of the 2 milligram? Rest of the 2 milligram is still in the mouth, so we can spit it out. So whenever the desired action is obtained, we need not take the extra drug, we can remove that drug. And this is not possible with the oral route, because if we give 5 milligram by oral route, and suppose 100% bioavailability is there, and if 3 milligram is absorbed and now the action comes, what happened to rest of the 2 milligram? We cannot control, because even that will be absorbed and we cannot stop that. So excessive dose we can control in case of sublingual route. Whenever desired action is obtained, person can spit the extra amount of the drug. So desired dose we can use. After that, we can spit the drug, or what we commonly advise in case of nitroglycerin is take the tablet sublingually. Whenever the chest pain subsides, either spit the drug or ingest the drug. So what will happen if a person ingests the drug? Almost all will be first pass metabolized. So basically we can terminate the action. So 4 main advantages of sublingual route are: number 1, there is no first pass metabolism. Number 2, we can use in emergency because of quick action. Number 3, self-administration is possible. And lastly, we can spit the extra dose whenever the desired action is obtained.
So we discussed bioavailability. It not only depends upon absorption, but also first pass metabolism. Now we will try to discuss how to measure bioavailability or how to calculate bioavailability. Suppose we want to calculate the bioavailability of drug A. Someone asked you the question, tell the bioavailability of morphine, or tell the bioavailability of aspirin, or tell the bioavailability of any drug XYZ. Can you tell? You ask me any drug, I can surely tell exact. Like if you ask me, tell the bioavailability of morphine, my answer will be bioavailability of morphine by intravenous route is 100%. Obviously. So any drug when we give by IV route, bioavailability will be 100%. So the question tell the bioavailability of this drug is wrong. The question should be tell the bioavailability of drug A by oral route or by intramuscular route. So we need to specify the route. Without the route, telling the bioavailability does not make any sense. Okay? So we need, now our question is tell the bioavailability of drug A by oral route. The problem here is when we give a drug, we give in the units of weight. Like we give the drug 100 milligram or 100 microgram or 10 gram. So we are giving the drug in the unit of weight. But when we measure the drug in the plasma, we measure in the unit of concentration. Like plasma concentration, if it comes, is 100 microgram per deciliter. So that means we are giving in a different unit and we are measuring in different unit. So first of all, we should know that when we give a dose, particular dose, if entire dose comes in the plasma, what will be the plasma concentration? Suppose when we give 100 milligram, if entire drug comes in the plasma, the plasma concentration will be 100 microgram per deciliter. Now we give by some route and the plasma concentration comes out to be 80 microgram per deciliter. So we can safely say that 80% has reached the plasma. So that means bioavailability is 80%. But for that we need to know if all the drug come in plasma, what will be the plasma concentration? That means if the bioavailability is 100%, what will be the plasma concentration? So by which route bioavailability is 100%? Yes, intravenous route. So for calculating the bioavailability by any route, first we need to give the drug by intravenous route because we want to know the 100% first of all. Clear? So what simple terms what we do is, suppose the question is calculate the bioavailability of drug A by oral route. So what we do is, first of all, we will give any fixed dose of drug A, suppose 100 milligram by intravenous route. First of all, we will want to give it by IV route to know the 100%. After giving intravenous, we will plot a graph between plasma concentration and time. A graph is plotted between plasma concentration and time. So we will keep on measuring the plasma concentration every half an hour and we will plot a graph. So the graph will come like this. Because the drug is given IV, initially concentration will be very high. But gradually it will start decreasing. So this total area represents our 100%. So this is our 100%. And this we can say is area under the curve. AUC, curve means plasma concentration time graph. Area under the curve by IV route. So this AUC IV represents our 100%. Clear? Now when the drug has become almost negligible in the plasma, now we will give same drug A, same dose 100 milligram, but by the route for which we want to calculate the bioavailability. So that means now we will give drug A 100 milligram orally and again we will plot the same graph. That means keep on measuring the concentration every half an hour. Now the graph will come like this because we have given the drug orally. So slowly the plasma concentration will increase, become maximum, and then it will start decreasing. So this area is called as area under the curve for oral route. Clear? So we calculate two areas, one by IV route, another by oral route, and now we can safely say what is bioavailability. Yes, bioavailability is area under the curve by oral route divided by area under the curve by intravenous route. Clear? This will come as fractional bioavailability. It will come in points, 0.2, 0.3, 0.5, 0.7. If you want to calculate in percentage, multiply it by 100. Or simply 0.2 means 20%, 0.8 means 80%. Okay? So this is how to calculate the bioavailability. Clear? Now related to bioavailability, there is another concept known as bioequivalence. bioequivalence. First question, what do you mean by the term bioequivalence? So we will divide it into two parts. Bioequivalence. So it says biologically equivalent, means these are similar. So when we are saying they are similar, means we are talking about more than one thing. Obviously, when we say this is similar to what? So obviously we are talking about more than one thing. So here we are talking about two things. Which two things? The two things we are talking about are two brands of a same drug. Remember, one drug may be manufactured by 10 different companies. So when we are comparing the same drug of one company with another company, here the term comes as bioequivalence. So bioequivalence, as the name says, if the two brands have almost similar effect, they are called bioequivalent, means biologically equivalent. Clear? We can take the example, like there is a drug called as aspirin. We all know aspirin. Different manufacturers are making this drug. Suppose one manufacturer make this as ecosprin, another make it as losprin, and suppose both of them contain same amount of aspirin, suppose 150 milligram. Both are containing same amount of aspirin. When we give ecosprin to a person and measure the plasma concentration, the plasma concentration comes out to be 100 microgram per deciliter. Remember, these are all hypothetical values. Okay, and when we give losprin, the plasma concentration comes out to be 90 microgram per deciliter. Are they bioequivalent? No. Suppose instead of 90 we make it 95. Are they bioequivalent now? Suppose instead of 95 we make it 99. Are they bioequivalent? Suppose instead of 99 we make it as 99.9999999. Are they bioequivalent? So obviously we need to draw some line, because even if we give ecosprin to two different person or same person, after some time the plasma concentration will not be exactly same. Human body is a biological tissue, so there will be some variations. So we must allow some variation, and that allowance which is seen is plus minus 20%. Means if ecosprin is giving a plasma concentration of 100, then losprin, if it is between 80 to 120, we will consider it as bioequivalent. If it is less than 80, not bioequivalent, more than 120, not bioequivalent. So bioequivalence means if the two brands of a same drug has almost similar bioavailability. Similar means plus minus 20% is okay, but it should not be more than that. Clear? Now most of the drugs which are present in the market now, they are bioequivalent, because now whenever any new company want to make the existing drug, they have to show that it is bioequivalent to the original drug. So bioequivalence studies are done, only then the drug is approved. So most of the drugs which are existing in the market are bioequivalent, but you need to remember one exception, and that is phenytoin. Different brands of phenytoin are not bioequivalent. Like we can take the example, two brands of phenytoin are there. One is dilantin and second is aptoin. No need to remember the brands. This is just an example. Suppose both of them contains 300 milligram of phenytoin. A person has epilepsy. We know phenytoin used for epilepsy. Person has history of seizures, and the person was started on dilantin, 300 milligram phenytoin, and the person is well controlled. Person is taking this drug since 6 months. No seizure has occurred. Person is totally controlled. After 6 months, the strip of phenytoin finishes, and this person go to pharmacist that give me phenytoin, dilantin 300 milligram. So the pharmacist says that I do not have dilantin, I have aptoin. You can see aptoin also contains phenytoin 300 milligram, so you can use that. So that person start taking aptoin, 300 milligram phenytoin. But on third day, the person developed seizure. Why this happened? Because phenytoin and the different brands of phenytoin are not equivalent. So dilantin and aptoin are not equivalent. So aptoin may not give same plasma concentration. So phenytoin shows the phenomenon of non-bioequivalence. So means in case of phenytoin, brand change is not recommended. If we change the brand blindly, the drug may not be effective or the drug may be even toxic because we do not know that what plasma concentration will come from that brand. So different brands of phenytoin are not bioequivalent. Okay.
So this is the importance about the first part of pharmacokinetics, that means A for absorption, and related to absorption we also discussed the concept of bioavailability. Okay.